Hello, everybody, and welcome to our virtual speaker series for the Healthcare System Transformation Project under the Rhode Island Commission on the Deaf and Hard of Hearing. My name is Christine West, and joining us today, we have Dr. Michael McKee. He is an MD as well as an MPH. And he works for the Department of Family Medicine at the University of Michigan Medical School, and he works at the Family Medicine and Deaf Health Clinic at Dexter Health Center. Welcome, Dr. McKee. Thank you. I'm so happy you could join us today. First of all, I'd like to ask you about your Deaf Health Clinic. Can you tell us a little bit about your model and how your service delivery works? Yes. So we've tried to set up a deaf health clinic that can be replicated in other locations. The clinic itself offers a number of things that other clinics don't offer. For example, we have 3 people working together in sign language. We have a clinician, we have a psychologist, a social worker, all of whom sign, and this is not easy to find, we understand that. But that's our model of the clinic, and we're hoping that this model is replicated, at least in part, by other centers. And we're hoping to show those centers that these models could be set up regionally or even statewide. And if they can't be done in multiple locations, they could be done in different parts of states. The point is that these clinics are accessible to deaf people. The communication is direct. The clinicians work hard on access through sign language, and we also want to emphasize that we serve hard of hearing people as well. So in that case, the communication needs may be different. We might use a laptop. And the other thing is sometimes doctors are a bit distracted by their own laptops, so we put those aside and we use a scribe to keep note of the encounter. And then we do have social workers and behavioral health experts who focus on psychosocial crises that might arise in a deaf person's life. And unfortunately, some of those struggles in the family or at jobs or in other situations, dealing with insurance, maybe abuse, those things do impact the health of deaf and hard of hearing people, the physical health. So we feel that it's very important to work together. So we have our social workers, and what we do is a warm handoff. Once we identify that a deaf person has a particular psychosocial need, we bring in the social worker and let them take care of the one-on-one interview to get more in depth with those types of problems. So we have primary care doctors, and we work with people from infancy all the way through adulthood. And when we set up the clinic, we may have staff who are hearing and don't know sign language, but there are different ways for them to communicate with deaf people. We train them to either type messages to learn some sign language. Of course, I have staff that works with me and all of them can sign. And then we have trainees, and we make sure that our staff is aware of the do's and don'ts of deaf culture. For example, if you have a patient in the waiting room, rather than yelling out their name, you instead would walk up to them and maybe tap them on the shoulder to get their attention. And then instead of walking into the exam room and surprising the patient, we have a system where you press a little button and a light flashes inside the room so the patient isn't surprised when you walk in. It's little things like that that go a long way to help the deaf people feel more comfortable. We also have a lot of written material that can be changed into video format. For example, our surveys, so that deaf people can watch the survey, answer the questions in sign language. Those are the types of things we like to do at our clinic. That model that you described is just so impressive. it feels so comfortable. It's very accessible and friendly, very welcoming. The fact that you have people using sign language. And the model not only seems to address physical health, but mental health, behavioral health. The fact that you use social workers who might identify other issues that are going on in this individual's life. Everything seems to be put together into a nice service package. And you mentioned that it's valuable to not only deaf people, but hard of hearing people. So tell me more about the value of holistic approaches. Well, the minute a deaf person comes in, they have access to communication. And so right away, they're pleased. And then they find out new information that they've never known about themselves for the first time. And so we do a lot of catching up. And sometimes that requires more than one visit to our office so that they get caught up on their health history. We might do a review of the medications they're taking. We explain what the medications actually do. We help our patients understand that it's not just the clinic itself. We've actually looked at studies that say that when there is adequate communication for deaf and hard of hearing people, it actually impacts their ability to follow the medical recommendations. And it obviously would help to improve outcomes. So we have fewer people visiting the emergency department, fewer people being hospitalized, and fewer negative results. So the treatment, all in all, goes much better. And that goes back to communication. Having adequate communication leads to much, much better health. Also, for mental health as well, unfortunately, in the United States, people struggle with access to get mental health. So we work closely with our social workers, and we train them to be a good model that could be replicated in general to any patient. And this is a better guarantee of outcome as well. There are certain benefits. And we certainly will need more future training for social workers and doctors to embrace this type of approach. But I feel like there is a wave of more knowledge nowadays, and I think for the next deaf cohort, things will be much, much better. There is one publication that shows that the benefits have improved for healthcare management overall. So if you look at integrated health models, where you have a family doctor and a social worker working together, you're managing a large system of needs. And we've shown that we can lower depression and anxiety. We've tested people before and after by using this model. And so we know it has an excellent impact on people. Oh, that's great. I'd really like to know more about you and your personal journey, especially your decision about becoming a doctor, your experiences growing up. When did you know you wanted to become a doctor? Was it at an early age? What was it that led you to getting into this field? And what barriers did you have to face and overcome? Sure. Well, when I was born, my parents didn't know whether I was deaf or hearing. They had no way of knowing until much, much later. I was 2.5 years old, and I still wasn't picking up language. And my family could hear. The testing at that time was to see whether I was deaf or not, but obviously it was given in a delayed fashion. I was 2.5. Nowadays, of course, we have these screenings for infants, and that's nationwide. But back in the 60s, those kinds of things weren't available. So there was a delay. Again, they discovered my deafness when I was 2.5, and I had to catch up learning language. I would say I was probably 14 years old when I realized, together with my family, that I should get together with more deaf people and learn about deaf culture. And that's when I picked up sign language, because lip reading without sign language can be tricky. So at that time, when I was in with the deaf community, I remember thinking, I really, really loved science. I wanted to learn more about biology and nature, something I'd always really loved. But the concept of actually working with people didn't come along until later. At first, I thought I might become a veterinarian. And then later, when I was in the deaf community and talking with a lot of my friends and colleagues, I thought, why not become a doctor instead of a vet? So I transitioned later in high school. I was told a lot of things when I brought this up, by the way. I was told I couldn't do it because I'm deaf. I experienced a lot of negativity, but I thought, there might be a way to make this work. I mean, they were saying, how are you going to hear the breathing and heartbeat with the stethoscope if you can't hear? But that didn't stop me. By my junior year, which I know is pretty late in life, people had been identified out there in the community who were working in the healthcare system, including 3 deaf doctors. So I'm not the first deaf doctor. And I'm really, really pleased that I had 3 deaf doctors to pave the way for me. One doctor, Dave, who works as the chairman of the Department of Family Medicine here, actually wrote a book called When the Phone Rings, My Bed Shakes. And he tells different stories about his experience of being a deaf doctor. So I read that book probably when I was in high school, and it actually helped me start thinking about doing it myself. So I reached out to all 3 of the deaf doctors, and I wanted to know about different technologies they've used, how they overcame barriers, and how they prepared for medical school. And by college, I was really ready to move forward with this, so I hurried to take the test called the MCAT, M-C-A-T. And then I went ahead and applied to medical school. I got into the University of Florida. I know we have alligators here in Florida, but that's my home state. And I had a wonderful education all 4 years. There were positive and negative experiences, excuse me, would you mind telling me a little bit about your experiences, positive, negative, and any discrimination? Well, being deaf, one always has to prove oneself. There's a lot of that going on. You have to prove yourself to other medical students. You have to prove yourself to show that you can do everything. You have to respond appropriately to questions. You have to demonstrate that you have good grades and that you're a good studier and a good, highly motivated student. So you're constantly proving yourself, much more so than non-deaf students. Lots of deaf people will verify this, that, with your attendings, with your residents, you just have to really prove yourself. So, and usually after 1 or 2 days, people relax, they see that you're competent, and everything is fine. But I did have one really bad experience. I was doing a rotation in pediatrics, and everything went really well. The other pediatricians were wonderful. In fact, I was actually thinking about becoming a pediatrician myself. But as I neared the end of that rotation, you have to take tests, you have to be evaluated, you have to have good grades. A certain percentage of the evaluation applies to your grade, and that's done by the resident, and one is done by the attending. And then the exam, obviously, and that factors into your grade. So it's a number of criteria that go into that. I did really well as far as I knew. Everything went very smoothly. My grades were perfect. And I remember when I got my grade back for the overall grade, it was a fail. I had failed. It was my first time failing. So I asked to meet with the director, the leading clerkship. And at first they were resistant. They didn't want to meet with me. So I pushed it a little, and finally I was able to get a meeting. And I asked, I'm surprised I failed. I thought the evaluations went really well. I was prepared for the exam. I was very surprised that I failed this. And the doctor wasn't attending, looked at me and said, "You are taking a place from another student who will become a successful doctor." I was so shocked. He actually said, "Deaf people can never become successful doctors." It was a very awkward moment, to say the least. And here it is, the head attending. So I actually had to fight to get that grade amended. I hope it's the only time I ever have to use the ADA to help me in situations like that. So they had to disclose the grade, and it had to be repaired. But it was a bad experience. Otherwise, though, I have to say it was a good experience. The proving myself was actually a good opportunity to learn. I learned so much in the process, other than that one very negative instance. The support I had was very good. This was before we had a lot of interpreters. So I used some interpreting, some note-taking, and it can be a lot of information overload. So in my third and fourth year, I actually had different rotations. And that's when I had a designated interpreter with me, which was a tremendous help. I would have missed so much without them. We typically worked in groups. We'd have a cohort with a few students. We'd have a senior resident and an attending, and the group could be fairly large, 10 or 12 people. It's impossible to lip read that many people. So having an interpreter really helped out with access for me. And at that time, I realized I had to be a self-advocate, that I had to ask for exactly what I needed. And to be honest, sometimes I felt a little shy about it. I didn't want to rock the boat. But it's important to advocate for yourself. I know what I need to do my best, and I know what types of accommodations are best suited for my needs. So I had to ask for those very specifically. And luckily, I did have the support of the ADA. Imagine the world without ADA. Think about all the other doctors who had no support. I'm so grateful for the ADA and that it was there for me when I needed it. Wow, thank you for sharing that experience. Related to medical school and your medical education, you were just talking about your experience with discrimination, and I wonder if you would mind talking about the technical standards for medical school. I know that you wrote about it. I wonder if you could just talk about it a little bit for the people who are watching this talk. The technical standards for medical school and how those standards could actually become a barrier for deaf and hard of hearing people in healthcare professions. Sure. The technical standards are a way of knowing that a person will be able to be qualified for the position in the first place. So in the olden days, they would ask you things like, these were organic. It was called the organic technical standards. And what that really meant was it's a very binary situation. Can you hear or not? Can you see or not? Can you move or not? Can you lift things or not? Do you have the ability to process things mentally or not? It was very black and white. And we realized a new concept could be added, like, can you do the job with a reasonable accommodation? For example, with a stethoscope that could increase the sound or had a visible readout, would you be able to hear what you need to hear in order to do your assessment? Yes or no? So you could answer those questions more easily. The old model really did kind of discriminate against students. The newer model, and we realize this, was much more inclusive. And, people are specializing more and more these days. So there's a much broader standard now, thank goodness. We want diversity in the medical professionals. We don't want everyone to look and be the same because our patient population is diverse. So we really highlight diversity. And we want different individuals in different specialties. People go into anesthesiology or surgery, or they may become psychiatrists, whatever. And with technology, it's possible. And more, this is acceptable by medical schools. We do have a group here that really pushes for more of that access, so that the old organic functional test was dropped. And now we have one that's much more related to, can you do certain tasks with accommodations? And, you know, the old standards were actually a violation of the ADA. So this is a big improvement. It's a change that we're very happy to see. It took a while to get there, but now this is the standard moving forward. So for future deaf and hard of hearing people, they can look at other healthcare fields and be eligible and decide for themselves what they want to do. Thank you. Now, related to medical school, what advice would you give to medical schools related to deaf and hard of hearing applicants, those who are applying to medical school? Deaf and hard of hearing, plus the medical schools themselves. How can they be welcoming to deaf and hard of hearing students, be more friendly and welcoming? And what do you advise students who want to become doctors? Okay, well, for potential students who are considering getting into medical school, study hard. You have to be prepared. There's just no way around that. You've got to be a serious student, and you have to be able to focus and read. You have to really enjoy learning and the learning process. If it's really not exciting for you, this is probably not the field for you. Preparation and studies are just so important. It's also important to think about strategies that are going to help you. And there's so many of them. You know, one size doesn't fit all. So students themselves, some may want to use American Sign Language and have an interpreter. Some may want to use the oral approach by lip reading or CART. Or maybe they want a mixture of services and resources, and that's absolutely fine. The most important thing is that you get what you need. Don't be silent and don't just take anything. Try to be assertive and ask for exactly what you need. At the same time, try to understand that people do need to be educated. They're just not aware of us. Try not to let that make you angry. Just be patient and educate them. For the most part, the barrier will be broken down and you'll be fine. Don't think of it as a negative, but an opportunity for you to do some teaching. People eventually do become your partner. So before medical school, what I suggest is look at the situation. There are different areas in the United States. You know, they're not all the same. And it's important to recognize that your deafness is not a negative. It actually is a positive. It's a gain. It enhances diversity. Disability is a plus because it enhances diversity for the service provider. It's cool. It's unique. It's a plus. You know, don't think of the negatives because you'll see that attitude, but the positives far outweigh the negatives, and things really are changing. So it's a matter of reframing the current understanding. Sometimes people just aren't sure what to do. And the important thing is to sit down with them, talk to them, tell them what you need early. I mean, don't wait until your first day of medical school to talk about what you need. So you've got to be prepared. There are all sorts of technical devices. There are all kinds of resources. You can share and teach. You can recommend different websites. So there are lots of ways to educate people, and I recommend that. Thank you. I wanted to ask you about your mentorship program. that seems important too. The AMPHL, could you talk about that organization and the mentorship opportunities? Is it important for future medical students? Yes. So right now, we are still developing that, different ways to provide mentoring. And we have a list of various recent graduates working in different areas and a variety of staff positions and in a variety of different types of practices. And so what we want to do with the list of different locations is match them with the appropriate student in training. It's really important that the trainee talk to the existing facility. That's something that I did. I reached out to doctors and said, how do I do this? What do I do? What technology can I use to overcome the barriers? And really what's helpful is to think about what fits me best and make it easier for the people providing the accommodations. So you can do this mentoring through email, you can do it through video phone, you can do it face-to-face. But what we like to do is have role models that help the students find out about future opportunities, whether it's through research, whether it's through clinical experience. We like to give students opportunities, and it may be a struggle. They might find out that what they thought they wanted to do was just so full of hearing people that maybe it's not an environment they want to work in, and they may decide to do something else. But if it is something they want to do, that's fine. So we help with strategies. Our organization, AMPHL, the Association of Medical Professionals with Hearing Loss, AMPHL. And we have amphil.org, and you can open up that website and look at all the resources we have. It's just tremendous as far as supporting students, providing mentorship, providing resources. And so I'd encourage you to take a look at the website. Thank you. Another topic I'd like to get to is you mentioned a little bit about the importance of deaf and hard of hearing healthcare professionals and diversity and the value of diversity. And you said that it can be beneficial to the deaf community, plus beneficial to the hearing community. So could you talk about how it benefits both communities? Yes. I have been talking a lot about the benefits to deaf and hard of hearing people, but interestingly, once we set up our clinic, a lot of parents of our patients who brought their kids there, they might have had kids with other disabilities, and they found themselves wanting to join our clinic because of our approach. It actually merges well with other disabilities. Maybe the parent themselves struggled with a health problem, and so our approach was very meaningful to them. A lot of it has to do with the eye contact and the fact that we want to be helpful through our communication, because it's interesting because here I am a deaf person and my focus is communication, but actually it helps me to be there in the moment. And sometimes, hearing doctors are kind of multitasking. They're doing, several things at the same time, and they're not really looking at the person in front of them. So that's one big advantage of the diversity, is that it helps people with disabilities, all sorts of disabilities. And I was really struck by the impact it had on other people with other disabilities, plus our cultural sensitivity is important. So first of all, communication access, as we all know, that's very helpful. And it has a positive impact on managing healthcare, understanding the uses of medicines. You will understand why you need to take this particular pill every day instead of, hey, it's not really doing anything, I'm not going to take it anymore. So it has so many positive impacts on people. And something I want to study later, because I really believe that diversity, whether it's diversity of deafness or other kinds of disabilities, having doctors and nurses with disabilities they have experience and they can relate to patients in a very different way. And that relationship, that compassion, and that in-depth understanding of what it's like to have a disability is significant. There are studies that show that if language is accessible, then health outcomes are improved. There are fewer hospitalizations. There is better control of diabetes, depression, anxiety, and a whole host of benefits. That's something we really need to research more as it pertains to deaf and hard of hearing people. But it's a pretty new field, disability studies. Thank you. I appreciate that. I'd like you to talk about healthcare disparities related particularly to the deaf and hard of hearing community. I did read some research, and it talks about there are 4 basic issues having to do with healthcare disparities and 6 recommendations for all public health entities. Would you explain that research? What are some of the disparities? And what are some of the recommendations for public health professionals going forward? Sure. So deaf and hard of hearing people, there are various groups within that population. For deaf people who use sign language, communication access is very difficult to provide. It's not there in many cases. And that can affect mental health as well. For deaf people who don't have language access to things like nutrition, to basic health information, that fund of knowledge is simply missing in many cases. If you're thinking of a group of hard of hearing people or people who become deaf later in life, they might have had some access to language, but they still have disparities because they may have had misunderstandings or difficulty really obtaining the information. And their fund of knowledge, although it tends to be a little bit better than deaf people who sign, it's still minimal. And so management of their problems and coping skills and the psychological issues are really, really challenging. Imagine if you grew up being able to hear and suddenly you became deaf. You'd be very isolated. At least the deaf community who signs has each other, and so they have a group affiliation. But for hard of hearing people or late deafened people, it's very lonely. And communication breaks down, and especially if it's a brand new experience, having the coping skills and the communication skills is really a struggle. And unfortunately, some of the technologies that we have, like cochlear implants and hearing aids, are just not affordable. So those are continuous barriers. When you look at both groups, the signing deaf people and the hard of hearing people, they use the emergency room more. And we do have some data for hard of hearing and hearing impaired people that the use of the emergency room is very high. And the readmission rate after 30 days is very high. So that's a metric that we use that shows us that something is wrong, that something is broken down, was misunderstood, medication was not correct, or the person wasn't following the protocol for some reason. So we do have research that shows that communication breakdowns are the cause of that 30-day readmission uptick that we see. Some issues are also brought on by socioeconomic difficulties. People struggle with finding jobs, or they struggle with being underemployed. They may have poor outcomes because of poor insurance. They just can't afford the medications that they need to take. So that has a big impact on future health. Those are just a few examples. You mentioned that fund of knowledge, and it makes me think of health literacy. I wonder if you could talk a little bit about health literacy, what that means, And what can we do to increase the fund of knowledge for deaf and hard of hearing individuals? Should it start? I mean, obviously it should start in elementary school, middle school, high school. We need to educate our young deaf and hard of hearing students. And, you know, health literacy and increasing that fund of knowledge, I think they're so important. Can you talk about that? Well, I'll explain a little bit more about the fund of knowledge. I mean, literacy really just means understanding. For example, blood pressure. If you have a person who has a very low health literacy, they may not understand that their blood pressure is a problem, and they wouldn't know how to manage it because they don't understand the impacts of high blood pressure, that it could lead to a heart attack or a stroke. And healthcare literacy, once you get the information and understand it, you can act on it. That's the distinction. Hopefully you'll act on it in the right way. So once you have the information and you're able to process the information, you can make an informed decision about what to do. So it's a two-step approach. It's getting the information and acting on the information. So having health understanding, that's really, really a struggle for deaf and hard of hearing people, for people in general. So the best thing to do is have a model and protocols so you can have some sample communications. And this applies to everybody in their training. Everyone on staff should get this training. Have good communication, have good protocols, speak clearly. Sometimes the language is just too technical, and we have to change the terms and explain the terminology in a way that's more easily understood and less often misunderstood, because, you know, a lot of our forms are just written at such a high English level. We need to change that and make them easier to read. We could use pictures. They're very helpful. There's so many other ways to help patients. Also, we really need to emphasize that the patient should be able to teach back what we've just explained to them. So if we talk to them about, for example, high blood pressure again, and we recommend medication, exercise, avoiding salt, nutritious diet, it's important to ask your patient to teach that back to you. That way you'll know what they understood. And if they missed something, you can just fill it in. It's a simple way to correct a situation. And then you can be confident that they understood you. So I think one-on-one encounters are very good, but also the system itself, like the forms we use. I mean, the insurance forms are so hard to understand, and we need to simplify them and make them more user-friendly so that people can navigate them. Getting back to the message to schools, health literacy and that teaching back process, it just happens. It happens naturally through dialogue. You know, you and I pick up information from our families around the dinner table, but for deaf people, it may not happen. And so the schools have a bigger responsibility to help deaf students catch up. I'm a big believer that schools need to take the role of that incidental information sharing that other people in public schools are getting anyway. And so how do you read a nutrition label? How do you navigate the nutrition system, the healthcare system? A lot of people don't know. And then when they really do need it, at an older age, they don't have the skills. So another model is peer education. I think that's really significant. There are ways that you could encourage people to get the information in the right way, in a safe way, through a peer counselor. Maybe someone who's deaf, who's trained, and who can go out into the community and meet with people one-on-one to help them through the system, to help teach them, maybe share their own experience, or times that they made mistakes and what happened as an outcome. It might have been a mistake with medication, or it might have been a mistake with following recommendations. And it's nice to have a layperson explain the information. It's actually, they can do it better than a doctor can. So there's a more affinity with a layperson and more access to information. So we're looking at that issue of using lay people in the community here in Rhode Island. We've also noticed that there's some research that mentions social media, Facebook and Instagram, things like that. And deaf and hard of hearing may learn a lot from social media, but sometimes that information isn't reliable information. Maybe some of it is. I mean, how can we help people screen out the good information from the bad information? Well, Facebook, as using that as an example, you can be so overwhelmed with information because people are posting all the time in sign language, and you don't know if the information is correct or incorrect. It's important for people looking at Facebook to know whether if school could train you or someone else could train people to filter information. And it's important to recognize what is the source of the information, and is that a reliable source? So if the source is a hospital or the government or health department or an organization that's reliable, you could have more confidence that the information is correct because it's based on experience and knowledge. It's from a doctor, it's from a nurse. You're more likely to be able to trust them. It doesn't mean that other information is wrong, but what's important is you want to get the most reliable information. You could look at that information and then compare it to what you're seeing on Facebook and cross-reference it. And if the information matches up, then that's great. Then you know you've found a good, reliable source on Facebook. But it is easy to get overwhelmed, and that's not just deaf people. Hearing people get overwhelmed by all the Facebook postings too. It's a challenge, modern day challenge. Going back to health literacy, I've noticed that deaf health clinicians where you work have community events. And I wonder if you could talk about your community events, what kind of information you share, what are they like? Because I could see Rhode Island hosting healthcare community events, and I want to know what they're like. Well, first of all, it's a wonderful way to give back to the community. We try to host them on a pretty regular basis. We'll have different people giving talks to the audience, and we give them plenty of opportunity to ask questions. And they pick the topics. So we ask them what they want next. They'll say diabetes. How about next month? They'll say cancer. Or the following month, maybe lung disease or heart disease. So we let the consumers choose what they need. And then local organizations will tell us what's available, and we'll get the information together and do a presentation. Recently, we did a Facebook Live series on the COVID-19 virus, and really, really worked out. There are different ways to communicate with people using technology, and regardless of where the people are. We used to have smaller groups, and that's nice because you get to know them and meet them. It's face-to-face, and they have big needs. With these presentations, a lot of times the question and answer time is really significant. If it's for a hearing organization, it might be 10 minutes. But for deaf people, we give them a good half hour because people do have a lot of questions, and we want to really be respectful of that. And I think it's important that we all take responsibility to give back to the community and give people an opportunity to talk about their needs and also build trust in the community because, you're isolated in the clinic and you don't get to be part of the community. And if deaf people see you in the clinic, they don't really know who you are. They feel a little bit uncomfortable. But when they see you in public, you're a normal person, and you're trying to help, they get a better sense of who you are and they're more likely to trust you. So we started this back in Rochester, and one-on-one isn't always the best or the most efficient way to communicate with people. When you have an audience and you're talking about the same topic, you're actually getting, 100 or more people. Whereas with the one-on-ones, you're only getting a few, one person at a time. With the more public education sessions, we can get really in-depth and spend more time on an issue. So that's a plus. Obviously, deaf and hard of hearing people want to go and see a doctor who signs and have that direct communication instead of going to a hospital or a clinic with a hearing doctor. And maybe there's an interpreter provided. Does research show that, or is that, I'm just curious if a local community hospital or clinic is run by hearing people and maybe they're having a presentation on some sort of health issue like diabetes, and they're willing to hire an interpreter. Will deaf and hard of hearing people go to that event? Or are they more likely to participate in an event that's actually led by a deaf person, where there's language access directly? Have you seen any difference? Well, I think people are more comfortable with a healthcare provider that uses their language. And when people are comfortable, they're more likely to ask questions, they're more likely to share stories. If they're the only deaf person in the audience, they're a little more timid and a lot less comfortable. And their access, when it's open access to the communication, they get more out of it, for sure. You mentioned COVID-19, and I'm wondering, what's your experience been? What are you seeing that's different now in terms of healthcare results because of COVID-19? If you could give me 2 seconds, I just need to get a quick drink of water. It's ironic that you mentioned COVID-19 and I start coughing. Hold on 1 second. I'm going to grab a sip of water. Okay, sorry about that. Do you mind just repeating the question? Sure. We were talking about COVID-19, and I'm wondering, in your experience, how has healthcare changed for deaf people? What do you see that's different related to face masks, other PPE, other changes? And what future changes should we look to? Even things like telehealth and video phone calls with doctors and patients. What are you seeing now with related to COVID-19? Well, at my clinic, we've had a big impact. And the general public, there's been a big impact. At my clinic, we can use video phones. Our patients are very savvy with video phones. So we thought, oh, great, we can do this, and people are happy not to have to drive in. And there is still good access with our deaf patients. However, there is a downside. We try to encourage them to be comfortable with video visits. I have a video phone, but unfortunately other doctors don't. So we're encouraging them to sign up for a video phone so that they can visit with their patients through the video phone. Because if you can see the other speaker, you can always bring in one of our staff interpreters. So there's 3 people in the room, the doctor, the interpreter, and the patient. And it's just like a live session. If you don't have that, you're on a regular phone where no one can see each other. And so the conversation is much different. You don't have as much rapport. And if you rely on VRS, many of those interpreters are not medically certified. So we're really encouraging, and it's a struggle sometimes. I'd say my access has been very good. And you're right about the face masks and the other equipment. Our clinic was closed for a while, and some of the doctors moved to other places. So we all moved around a little bit. And deaf people were now trying to interact with staff who had no training with them, and they were wearing face masks, and that was very overwhelming. It was really a challenge for everyone. I mean, they could see me fine, but when they came in live to the front desk, they couldn't really talk to the staff. We tried to find different methods, but it was really a challenge. So things are a little bit stable now, but I don't know what's going to happen in the fall. You know, we're just keeping our fingers crossed. Either people can have virtual telehealth or they can have in-person health. One of the positives of telehealth is that you can set it up and it's there, and it gives people a tool, and it gives you an opportunity to have a better language match. And you can find out that, oh, I can use telehealth with this person and with that person. So it does really expand your opportunities for healthcare. Another thing is, hospitals struggle. Deaf patients, we tell them to make a plan and have a little bag ready if they have to be hospitalized, because it's really not an easy place to navigate communication with all the PPE. There are clear face masks, which are very nice to have, but they're not approved for inpatients. At my clinic they are, but they're not in the hospitals. So that's a barrier. And the face masks, they're used all over the hospital. Another struggle is for hard of hearing people. Imagine, if you're lip reading, you just simply can't understand anything with a face mask. You can't lip read, you can barely hear, and you're really left out of the communication. So we do have these portable units where people can read a typed message on an iPad. So it could be it could be captioned. And that's a good alternative. That's pretty helpful. So it also could even help with lip reading. And then there are these masks that do have a window, a small clear window. And there's also one called the clear mask. And so you'll see products out there, but there aren't very many of them right now. They're pretty scarce. So we'll see what happens down the road. But so far, getting people to follow the recommendations by staying home, social distancing, wearing a mask when you do go out in public. Sometimes the information, if it's just printed or it's done in spoken English and you're just reading captions, it may not translate perfectly. So we do a lot of re-education, and we have to actually repair misinformation. That's what it is, and even still we might have people who resist wearing face masks. I'm sure with COVID-19 and this pandemic, every state Department of Health does share information. Of course, it's in English and it's captioned. If they have funding, they may hire an interpreter and do vlogs and videos, which is great. In Rhode Island, we've really done a great job of that, I have to say. I know each state is a little bit different in terms of how they get the information out, whether it's in ASL or not. It seems like Michigan is doing pretty well with vlogs and information sharing. Yeah, we have an interpreter generally, which is really nice. So there are vlogs. In Michigan, we certainly support vlogs, and captioning is always important. You should never ignore the hard of hearing people. Sign language is one group of, users are one group of people, but a lot of people do rely on written information. So we have to make sure we do both things. You can also use diagrams, show a person coughing if you want to show the cough, or show a thermometer if you want to talk about temperature and fever. And you have to think about all the groups and subgroups within the deaf community, which is challenging, but it's important. Thank you. I do want to talk about data, the importance of data collection. For our project, we do send out surveys, and we want to collect data. And we know that this is data related to deaf and hard of hearing people, and it's very, very scarce at this point. To get the community involved in Rhode Island is really tricky. And so we think it's important for deaf people to be involved in data and surveys. How important is it for healthcare research? How it might impact state funding and budgets. The amount of data available could certainly have an impact on the state. Can you talk about that? Oh yeah, research is so important, and unfortunately, some groups aren't surveyed enough, and so that the recommendations don't get to them. There are deadlines and so forth, and studies have shown that for a deaf person who uses sign language, there aren't really that many respondents. The group of respondents is very small. People might join those groups. We'd like to see the groups be larger. And we want to make it possible for deaf people to participate so we can show that we have numbers, and we can also do more powerful analysis. We want people to be confident in the results that we get from these surveys. For hard of hearing people, we have data, and what's really interesting is that data identification is a challenge. We don't know who in that group uses American Sign Language, who was deafened later in life, who was born with hard of hearing. So we don't have the different discrete populations within that larger group. And so we don't really identify communication needs very well. So we need to collect better data, more discrete data. And sometimes people actually ignore questions. Like if they have a disability, are you disabled, are you deaf? They might not want to answer the questions. A lot of times the demographic questions are tricky to answer. So we need to study large groups of people. We need to include deaf and hard of hearing people. This is 16% of our population. So we want to make sure, and we have 1 million or more people who use sign language as their primary means of communication. So we want to be able to not only get the data, but interpret it in a more effective way. Our project is contracted with Gallaudet University, and their design will build our survey, and they'll be consulting with us. They themselves are deaf, and they're also very good in collecting data from deaf people. So we're excited about that. I think I've asked all of my questions, unless there's anything that you wanted to add before we close for today about the healthcare system and transformation. I think I'm all set. Well, thank you so much for your time. I'm so honored and thrilled that you joined us today. This interview was just fantastic. If people want to contact you, is that okay? I have your information, and I could certainly put in a slide with your contact information at the end of this presentation. I'm fine with that. Okay, great. Thank you very much. Bye-bye now.